Hepatic encephalopathy. It is a spectrum of neuropsychiatric dysfunctioning in patients with CLD characterized by impaired personality, intellect, consciousness. Intellect is like cognition. Consciousness means there will be altered mental status, patient will be confused. All these symptoms will be present. So this is hepatic encephalopathy by definition. Now what is the pathogenesis? It is the accumulation of toxins in the blood, mainly the ammonia, which crosses the blood-brain barrier and gets deposited in the brain. That leads to the impairment of brain functioning. Now, why these toxins accumulate in your body? The main and the most important factor is portosystemic shunt. And why that shunt develop in cirrhosis or CLD? Due to portal hypertension. Other causes like Budd-Chiari phenomena, congestive heart failure or surgical shunting may be there for portosystemic shunt, but we are mainly concerned about cirrhosis, and that causes portal hypertension. Now, how this actually works for encephalopathy, that hypertension? We ingest the ammonia in the diet, that is in the NH3 form, and that ammonia is absorbed by the portal vein. This is the portal vein. That portal vein carries the ammonia into the liver. Within the liver, actually this is within the liver, I just put it outside. Ammonia is converted into the urea. Now urea is very less toxic and easily excreted by the kidney, so no problem. Now what happens in case of cirrhosis? In cirrhosis, the liver is fibrosed, so there will be a lot of fibrosis and nodules, so that will lead to the obstruction of the portal vein. Now that develops the portal hypertension. This lead to the opening of the collateral vessel like this. It is not here, it is going directly into the heart, but it will go into the inferior vena cava and then through the heart. Now, but what actually pathology occurs? Now this ammonia, instead of going into the liver, directly enters into the systemic circulation, and from the systemic circulation, the ammonia enters into the blood and then in the brain. In the brain, it causes the further damage like astrocyte injury, edema of the brain tissue. So that is the main pathology for the portal systemic thing. Another thing is decreased hepatic functional hepatocytes. Liver is carrying out the cycle that is called as urea cycle, in which it is converting the NH3 ammonia into urea through various steps. Now what happens in case of decreased functional hepatocyte? Not only that the ammonia from the intestine can enter into the blood, but the ammonia which is produced in the body by metabolism like muscle breakdown or other metabolic process will not be converted into the urea. That will further lead to accumulation of ammonia. So two things are actually contributing towards this. Number one is detoxification, and second is no metabolism of ammonia. So both these factors are contributing towards the pathogenesis. Now what are the various types of hepatic encephalopathy? Type A is hepatic encephalopathy due to acute liver failure. Type B is due to portosystemic shunting with no liver disease, like it could be Budd-Chiari phenomena, congestive heart failure, or it may be surgical cause, any cause which lead to shunting other than the cirrhosis. Type C is actually what we are discussing right now, that is cirrhosis which lead to portal hypertension and then portosystemic shunting. That is the type C. So these are the various types. Now what is the clinical manifestation? The clinical manifestation is divided into various grading. Grade 1, we have no detectable signs and symptoms, that is grade 0. Sorry, not 1, that is 0. In grade 1, you have the altered sleep pattern. This is very important. Whenever you are taking the history of encephalopathy, you will ask about changes in sleep pattern like any insomnia or somnolence or reversal of sleep pattern. What do you mean by reversal? The patient starts sleeping at day and don't sleep at all at night. These are the most earliest signs and symptoms of hepatic encephalopathy, and there may be mild confusion or decreased ability to perform the mental tasks. That will be referred as grade 1. But what happens next? Next, the most important thing you have to remember is asterixis. What is asterixis? It is actually the inability to maintain the sustained contraction. If you ask the patient, and one of the signs we test normally is flapping tremor, it is actually due to the inability to maintain the sustained contraction of those extensor muscle. But if you ask the patient to close his eyes, he will not be able to maintain it in the closed position, or make a fist, he will not be able to make a sustained fist, so there will be relief, temporary relief. So inability to maintain the sustained contraction, and one of the sign we will test will be the flapping tremor. This is actually showing the grade 2 of encephalopathy. If you see hepatic encephalopathy patient with flapping tremor, so he is in grade 2. Now the patient may be disoriented in time only. He will not be able to tell what time of day it is. There may be some personality and behavioral changes, and there is marked difficulty in performing the mental task. In grade 3, what happens? There will be confusion. A lot patient will be totally confused. He will be disoriented in not only in time but TPP, time, place, and person. He will be totally disoriented, and he will be unable to perform any mental task. It was marked difficulty in grade 2. In grade 3, he was not able to perform, and in grade 4, the patient will be comatose. He may or may not be pain responsive, but he will be in a state of coma. So these are the 4 grades and the clinical manifestation. Okay, what are the precipitants of hepatic encephalopathy? What are the various things which can precipitate or exaggerate those signs and symptoms? Number 1 is renal failure. Why? Since renal or kidney is all involved in the excretion of ammonia. Ammonia excretion occurs through the kidney. In renal failure, that excretion is absent, so it will further lead to the accumulation of ammonia, so the symptoms will get exaggerated. That is the reason for renal failure as a cause of precipitant. Second is hypovolemia. Same reason. Hypovolemia means decreased renal perfusion. If the patient is hypovolemic, renal perfusion will be low. If renal perfusion is low, there will be less excretion of the NH3. So NH3 will ultimately accumulate in your blood and then crosses the blood-brain barrier, enter into the brain. So that is the reason for why hypovolemia is a precipitant of encephalopathy. And next is the infection. Infection has both generates, and there will be increased production of NH3 due to the inflammation, and there will be hypovolemia also. So they both lead to the increased production, decreased excretion, increased NH3, so they can precipitate this encephalopathy symptoms. Next is upper GI bleed. Upper GI bleed actually leads to the increased intestinal absorption of NH3. There will be more absorption of NH3 from the intestine, so ammonia gets accumulated. Actually, all these precipitants are directly or indirectly leading to the increased level of the NH3 that is causing the further symptoms. So that is why upper GI bleed can lead to precipitation of this. Constipation. Constipation also causes the increased NH3 production and absorption. So that is why it is the precipitant. So you have to keep in mind these precipitants, and these should be treated in patient of encephalopathy. In diuretic, those diuretic which are actually causing the hypokalemic alkalosis, those diuretics which causing the hypokalemic alkalosis actually results in the increased formation of NH3 from NH4 positive. Since NH4 positive is excreted from the body, it is easily excreted or not absorbed. NH3 cannot be excreted, it enters into the blood-brain barrier. So what hypokalemic alkalosis, NH4 is converted to NH3, so it leads to the increased formation of ammonia that can lead to the precipitation of these symptoms. And last is diet and some other drugs. What is the diet? Mainly the protein. Why protein? Since protein has amino acid which carries the nitrogen, and the protein breakdown will lead to formation of ammonia. So the protein diet can lead to increased symptoms of hepatic encephalopathy. Okay, last is drugs. Since encephalopathy is affecting your brain, encephalopathy affects your brain. So any drug which acts on the brain, like antidepressant, opiates, all these drugs can aggravate the symptoms of hepatic encephalopathy, so they should be avoided. So these are the common precipitants and how they can lead to the precipitation of the hepatic encephalopathy. Now what investigation you will do? The only investigation which is required is level of ammonia. If they are high, it may show, it will show. Most sometimes they are low and patient have the encephalopathy, but that is the only lab test which is relevant here. Then electro and EEG, it will show the triphasic wave. that can be done. CT scan and MRI, these are just done to rule out other causes, that is your differentials. ठीक है, to rule out other differentials. There may be some brain tumor that can be causing this, or some other metabolic causes. Now for the differentials, you have to do the differentials investigations for the differential diagnosis, which should be ruled out in case of alternate mental status. So we will not discuss them, we will only be discussing the specific investigation which should be done. Okay, after investigation, these are the differentials. Stroke could be there, so you have to do the investigation for stroke also. Brain tumor, it could be a mass in the brain, or it may be some infection or abscess. Hypoglycemia, that can lead to the altered mental status, so it should be in the differential diagnosis, or infections of the brain like meningitis and encephalitis. Okay, how will you manage this disease? Since it is a hepatic encephalopathy, the cause is actually the failure of the liver. Whatever you do, until you fix the liver, there will be no permanent cure. So the best treatment is treat the liver transplant. It will be the best, treat the cause. And you have to restrict the dietary restriction of protein to 30 to 40 gram per day, because protein is actually producing the more ammonia, so you have to restrict the protein. Precipitants should be managed. These are the just general consideration for the management. Precipitants, all the precipitants we have discussed should be managed accordingly, and avoid the CNS acting drug like opiates or antidepressant. These should be avoided in this case. Now what is the specific management? Specific management will be, the first line is lactulose. It is present in the form of syrup, so 30 ml per oral OD or BD, almost 3 to 4 teaspoon maybe there, that equal to okay. Now this is given. What is the mechanism of action? It converts ammonia to ammonium. NH3 is neutral, NH4 is charged ion. When in the intestine you have the NH4 or charged ion, it is not absorbed from the intestine, it is excreted in the feces. So lactulose, what it does, it converts ammonia to ammonium, so it is not absorbed, so we decrease the input of the ammonia. That is why it is very helpful. The adverse effect observed with lactulose is diarrhea, bloating or electrolyte loss. That should be kept in mind, and your goal should be, how much lactulose should be given? 3 to 4 stools per day, that is the goal. So this is the first line specific management, that is lactulose. The second drug which we most commonly use is rifaximin. Historically we use neomycin, but now rifaximin is mostly used. The dose is 400 mg per oral and 3 times daily. It is a tablet. So mechanism of action, what is the mechanism? In the gut you have the bacteria like E. coli, Klebsiella, Enterobacter. These bacteria actually produce the ammonia. They lead to the production of ammonia. Now what this rifaximin does, it kills those bacteria. When these bacteria are killed, the production of ammonia is decreased, so that lead to the low level of the ammonia in the blood. That is the mechanism of action of rifaximin, and its adverse effects are nausea, vomiting and edema. Aminoglycosides like neomycin, it is having similar action, but what is the disadvantage is that rifaximin is not, it is actually the derivative of rifampin, which is anti-TB drugs. Okay, rifaximin is not absorbed into the systemic circulation, it will remain in the intestine, so it has no systemic side effect. What happens, what was wrong with aminoglycoside? They are very ototoxicity and they are very nephrotoxic. They can lead to very disastrous adverse effects, so we are not using the aminoglycoside. Instead we use rifaximin, which is the better drug. These two drugs are mostly used for the management of this. Then we have a new drug, new treatment strategy, that is LOLA. It is actually L-ornithine and L-aspartate. What it does, it has ornithine, so ornithine is a part of urea cycle. What it does, it increase the urea cycle. So what will happen? It converts ammonia into urea, and that can be cleared from the blood, from the body and the blood. And then we have the zinc. What does zinc do? Zinc also increase urea formation from ammonia. So these two treatments are concerned about conversion of ammonia into urea. The first two are to decrease the load of the ammonia into the body, And the definitive treatment, the best and the most definitive treatment for this is liver transplant. That's it.